Greetings. My name is Ann Grace, and I'm the IWMF's Wellness Program Coordinator. And I'm so excited to welcome you to today's wellness webinar with our esteemed guest, Dr. Shirley D'Sa, who's joining us today from her family vacation in Stockholm, Sweden. Thank you so much for being here, Dr. D'Sa. As you may know, Dr. D'Sa is one of the world's best medical resources when it comes to the rare disease of Waldenstrom's macroglobulinemia. And today we're going to be learning more about her most recent research, which measured quality of life in Waldenstrom's patients using wearable technology. Dr. D'Sa will also shed light on the relationships among anemia, fatigue, iron, and energy levels relevant to this population. And I know I personally will be listening very closely to this webinar to learn more about the variables involved in the measurement of quality of life and how we can improve it. As the daughter of someone with Waldenstrom's and the IWMF's Wellness Program Coordinator, I'm really interested in bettering the quality of life for our Waldenstrom's community. And spoiler alert, I think it might have physical activity involved in it, right? I think we might find that physical activity is a way to improve. So before we get started, a quick shout out to our wonderful staff who are here to help manage the large group. We had over 270 people register for this, which has broken the record from all of our wellness webinars that we started over a year ago. This is hands down the biggest one so far. And we have how many people here live in the group right now? We have almost 100 people here live. So thank you for coming. Thank you for coming from all over the world to be with us today. And as a reminder, just stay muted and feel free to type your questions as they arise into the chat. And at the end, I will do my best to assimilate them and funnel them to Dr. D'Sa. So pleased that she's here to answer these questions. And thank you again to Rick Savoy for editing this video. So a little about Dr. D'Sa. So much I could say about her. She is one of those rare doctors who is extraordinarily passionate about the patient voice and how understanding the experience of living with Waldenstrom's should impact its treatment in the medical arena. And we're also very fortunate to have Dr. D'Sa on our scientific advisory committee here at the IWMF. And also big congratulations, if you want to put your hands together, for Dr. D'Sa, who recently received her full professor title, teaching hematology at the UCL Cancer Institute at the University College London. She's also the consultant hematologist and clinical lead for the UCLH Center for Waldenstrom's macroglobulinemia and associated disorders at University College London Hospital's NHS Foundation Trust. She is the hematological lead in the Joint Neurohematology Service at the National Hospital for Neurology at the Institute of Neurology, Queen Square, London. And that, my friends, is the largest center dedicated to Waldenstrom's in all of Europe. So if you're lucky enough to live in or near London, you might actually have Dr. D'Sa as your doctor. So I would love a quick show of hands if anybody has been treated personally by Dr. D'Sa. And we're seeing, a lot of folks who are not on camera. You could also type it into the chat. I see a lot of folks raising their hands in our Zoom room here, which is, you are one of some lucky folks. So let's go ahead and get started here. I'm just going to throw to you, Dr. D'Sa, with a surprise question to start things off before you start sharing your slides. How on earth do you do it all? I am curious if you might let us in on what your go-to self-care practice is.
Wow, that was an unexpected one. It's been a kind of a work in progress, and it remains so, because I think, throughout your life, you evolve, you learn new things, and you have different stages of life. So I've been a working mum pretty much all my career. And I've got three great kids who are not kids anymore. One is 26, one is 22, and one is 18. So back in the day, it felt more difficult because it was a question of going into work, coming back, making sure they got to school, trying to feed them and stuff like that. As they've got older and more independent, they are an amazing trio, and I have great fun with them. My husband's been a fantastic help in the joint effort. So nowadays, I do. What I've done is I've tried to get a bigger and better team. Well, not a better one, but a bigger team at UCLH to help work on Project WM. And I've been very fortunate to work with some wonderful young investigators who actually do a lot of the heavy lifting, which is great. And that means I can hopefully step back and take a slightly, higher level view. So that's a great help. And my other go-tos are reading history. I love learning about the empires that have ruled the world and still do. I'm a child of the empire myself, the British Empire. I love listening to authors when they come to London to speak about their latest books. I do try and do some yoga, but I don't get to do it often enough, I have to admit. So yeah, work in progress. But I think above all, I really, really love working in the world of Waldenstrom. And so that is not itself, it doesn't feel like a burden. It's real privilege, and I enjoy it a huge amount. And for me, the thing that gives me most energy is linking up with people. And I'm really fortunate to have met loads and loads of people. They happen to be affected by WM and related conditions, but it's really enriched my career, I have to say. So that's my answer for you.
Thank you so much for giving us a little glimpse, a behind the scenes glimpse. And of course, I'm pretty excited that you do yoga, Dr. D'Sa. So without further ado, please allow Dr. D'Sa to give her wonderful presentation, and we'll hold those questions for the end.
Great. Well, thank you very much. And I'm hoping you're still seeing my first slide, which, first of all, thank you so much for inviting me to meet with you all and give this talk. Thank goodness for the wonders of technology on this occasion. And actually, that is a theme of my talk today, because technology is everywhere. And I've been increasingly fascinated by it because it has a lot of promise in the practice of medicine. It is actually already arrived. My belief is that we as clinicians, as researchers, should embrace this. Otherwise, it'll all happen without us, and perhaps the best results won't come through, because you've got a lot of great techie people, a lot of bioinformatic geniuses around there, but they don't really see patients. So we need to have a Venn diagram where we all connect. So I'm going to talk about quality of life in WM and other tired topics. I like that, Anne Grace. That was a great little phrase. And I will touch upon the work we've been doing with wearable tech. So here are my disclosures. And now we move on to, first of all, actually, wellness. This is a wellness webinar. And I'm sure you've discussed this many times during the course of the previous webinars, but the definition of wellness is very varied. It depends on expectations that we have, our stage of life, our age, our general health. And there are many dimensions to wellness. There's physical, emotional, spiritual, social, and that again means different things to different people. If you happen to also have WM, then that's a further dimension, or perhaps a few dimensions. It's a condition that is with you for a long, long time. It's probably been there for much longer than before it was diagnosed. And even when it has been diagnosed, many people feel fine. They feel fit and healthy, although they may feel the burden of knowing the diagnosis. And that is something that plays into well-being. So the thing is, how does one approach this depending on what stage of your WM you are in? Because actually, wellness is a proactive choice to make if you possibly can. Easier said than done if you're feeling down, but if you can work towards that, and there are many ways which can help, it's really valuable to shift the focus from having the disease to fully living, kind of being in charge of it if you possibly can. Now, fatigue, as I'm sure, I think we've all experienced it at some time or other. It seems very prevalent in the world today. There's so much going on, and this itself is fatiguing. But it's particularly common in people with WM. It's mentioned very often in my clinic. It's quoted a great deal in lots of studies and write-ups about WM. And it's undoubtedly multifactorial. So it can stem from a combination of disease-related factors, treatment side effects, underlying conditions that may exist already. And in particular, for example, factors such as anemia, hyperviscosity, this chronic inflammation that seems to undermine and be present all the time. There may be bone marrow suppression causing low blood counts, and then there's treatment-related effects as well. So addressing fatigue in WM really depends on what the underlying and most prevalent cause of the fatigue is. If the disease is very active and causing symptoms, then one needs to start treating it and bring it under control. There is also a means of, optimizing supportive care as needed, such as, if you have anemia, then there may be times you need a blood transfusion until your treatment kicks in and it works. There's this very strange, but well-documented relationship between iron use and people with WM, which was identified by Stephen Treon and his group. There is quite a complex way that the body handles iron. Obviously, we generally eat iron, and that's how we absorb it from our gut. But you also lose iron, and in health, women lose more iron than men through monthly periods, for example. Any bleeding can cause iron loss as well. But in WM, there's this strange mechanism by which the presence of WM somehow suppresses the body's way of handling iron. So even if you eat enough iron, you may not be able to absorb it well enough, and you can end up getting what's called functional iron deficiency. So this is something that is worth thinking about in terms of fatigue, and if you are anemic, because it's worth having your iron levels checked. And if they are particularly low and there's no other cause, such as bleeding, then people can get a great boost from intravenous iron replacement. And this is something we do not infrequently, actually, in our practice. So that's a little tip about iron. Hyperviscosity syndrome results from overproduction of IgM. And if it's particularly high, then you can get thicker blood, and that can cause sluggishness of circulation, and that makes life difficult. It slows your thinking, it makes your breathing more difficult. It's like walking through treacle. Your legs feel heavy, and it can build up very gradually. So again, another cause of fatigue in WM. The inflammation of WM is shared by other so-called plasma cell disorders. At the end of the day, WM is an immune disorder. The way it develops, fortunately, you end up with the overproduction of immune activities, and that leads to a chronic inflammatory state, which itself makes the body work harder. So that's another reason why people are quite fatigued with WM. The bone marrow suppression comes from infiltration by malignant cells, the lymphoplasmatic cells, which build up to varying degrees in different people. And if very substantial, then you get reduced number of blood cells being produced. There is also the matter of things like neuropathy, which can develop as a result of WM or IgM related problems. That can be very exhausting. It can be painful. It can make you struggle to mobilize, and therefore you need to expend more energy in just carrying out normal activities. It's also important not to ignore nutritional deficiencies. B12 deficiencies is more common than expected in WM and very easily corrected. You can have intramuscular B12 or oral B12, depends on your diet. So these are things that should be looked for and corrected if necessary. Vitamin D, I just throw that in there. It works in different ways. It's worth checking levels periodically, and certainly if you live in sort of non-sunny countries, probably having regular vitamin D supplements. It does so much in the body, well beyond bone health. That's an important part of it. Sleep disturbances are very common amongst many of us for various reasons. One of them, which can be, if you like, a medical problem, is if you have sleep apnea. That can inadvertently disturb sleep, which you may not be aware of at the time, but you can get long-standing sleep problems and daytime sleepiness. And the reason for that is that you end up blocking off your airway, and that's often given away by snoring. And you develop a buildup of carbon dioxide, and you get less oxygen than you need. And if that happens for chunks of the night, then the next day you're just out of sorts. So the way around that is to have a sleep study, especially if you snore. So you may have to ask your partner about that. Because if you have a sleep study, there are some really cool methods of giving yourself what's called CPAP, continuous positive airway pressure. They're much less large than they used to be, and they're very silent, and they can really make a difference to your general well-being. If you get secondary infections with progressive disease or treatment, that again can be quite, in the end, it adds to time because your metabolic rate increases and you need sort of further medications and stuff. Actually, very important, of course, is the psychological aspect, which is complex. Anxiety, depression, stress related to having a chronic illness can impact on energy levels in a way that's often very difficult to disentangle. People have different ways of dealing with stress. Some people seem inherently happy, others are more weighed down. And there's nothing wrong with either of those. It's just the way it is, but it's worth discussing that with either a significant other or a professional, and either considering talking therapies or even taking for a short period things like antidepressants that can just reboot the chemicals in your brain and make you feel a bit more able and sort of more motivated to do things. So how do we put all this together in a way that's helpful in the management of WM? How do we sort of quantify these? Did I move forward one extra? Yeah. So how do we make sense of quality of life, and why do it? Well, quality of life in cancer patients has been measured for many years using many tools which have been developed initially for the conduct of clinical trials, because it's mandatory to understand whether the new therapies impact on quality of life. Now, this has become more prominent, which is a good thing, and it's gone beyond simply clinical trial settings, because with some of the new therapies we have nowadays, which are taken continuously for very long periods, quality of life becomes an everyday issue related to therapy. Whereas if you have a block of treatment for, say, 6 months, you can then look forward to a period of treatment where you have time to recover and your system gets back to better shape, etc. Although this can take some time in different people. So there are many types of data collection exercises to get quality of life measurements from patients. Some are self-reported questionnaires, which many of you have probably filled out. This is the most common approach and relies on patients' perspectives. These are predefined questionnaires which have been tried and tested. There are interviews that could be conducted face-to-face or over the telephone. There are electronic tools, so these questionnaires can be done online. And there are a number of organizations around the world that are professional organizations that deal with these questionnaires, quality of life questionnaires, such as the EORTC in Europe, Euroqual, the FACET group, which is an American group. And their role is to develop a series of questionnaires which are more and more specific for different diseases. So there are some very generic tools, but there are also some more specific ones. So there's one for lymphoma, there's one for myeloma, there's one for other forms of cancer. So we have developed a great interest in this because my observation from the clinic is that it's a really challenging problem for many patients and not easy to fix. So there is subjectivity in self-reporting. There are cultural differences in the perceptions of quality of life. There's a difficulty in capturing complex existential concerns as well. So we need to try and work out how best to do this. So in fact, to give you some idea, there are many domains that are routinely assessed in the quality of life measurement. So there's physical health, emotional and psychological well-being, social well-being, functional ability, and spiritual and existential concerns. And you can see some subheadings there of what is addressed. Now, these are very vague, and whilst one can easily ask on a patient level basis, and that's what we do in clinic, how are you feeling? What's going on? You can report the results and follow that individual. If you're looking at bigger groups of people, you need something a bit more measurable, something that changes with treatment or doesn't change, or something that shows a trend and is reliable. So we set out in our group to find out whether the existing quality of life assessment tools are indeed fit for purpose for WM. And back in last year, 23, we basically did a study where we looked at a series. This was basically looking at this sort of quality of life questionnaires that exist, and we looked at them in respect of WM. So there are a number of questionnaires like QLQ-C30, EQ5D, etc., FACT-G, and so on. They exist, but they're not specific to WM. And our thesis was that they probably don't capture the story in WM. They were mostly validated for much broader cancers or even lymphoma populations. And they were also developed at a time when chemoimmunotherapy was much more of a standard, whereas now, therapies have evolved. So WM-specific aspects include the effect of the IgM, things like neuropathy, autoimmune problems. These are inadequately addressed by most quality of life questionnaires. So we do need a quality of life tool specifically for WM. And this will help us to optimize treatment options and improve patient care. So we have been collaborating with our Dutch colleagues, and I haven't actually got a slide for them, but I've seen their the voice project being publicized on the IWMF website, which I really urge you to partake in, because that's another way of addressing patient experience using the discrete choice experiment method. But we have been further involved in an international study, which is that based on the fact quality of life questionnaires are generic and don't address WM-specific challenges. And in this study, we evaluated the relevance of current quality of life questionnaires for WM patients and compared perceptions between patients and healthcare professionals. Because if you're sitting at my side of the desk, you can make certain assumptions, but it's not the same necessarily for the patient or their carer. And this study the study centres involved, which were mainly the UK and Australia, conducted a cross-sectional online survey between December 22 and June 23 of patients in these countries. And amongst the questionnaires, there were 415 questions. Now, none of them had all those questions. There were 14 questionnaires in which there were 415 questions in total. And people were asked to judge on a 5-point scale how relevant they felt the different aspects were. And there was data on demographics, symptoms, treatment preferences, and there was also free text responses. Now, this work has been submitted and it's been assessed for publication. And I'm not going to go into this in great detail, but you can see that there's a lot of rich data to come out of even a simple kind of survey of what people think about questionnaires. So there's a number of aspects that were asked about, such as fatigue, pins and needles, sweats, difficulty breathing, headaches, joint pains, weight loss. And you can see how in the red bars on the left graph, there are people who've previously experienced in red and they are currently experiencing in blue. And obviously, this is just a snapshot and the paper is yet to come out. But these are this is the ranking of the symptoms that people felt were the most important to them in the questionnaires. That these are the ones that they felt were most relevant to be asked about. Whereas, for example, abdominal swelling was felt to be less important in general in WM patients. So these things are important to explore in more detail, and that's what we're trying to do. And on the right side, there is, again, a pictorial measure of what was felt to be not relevant in the survey results, and that included financial support, post-traumatic stress, sexual dysfunction, education and training. Now, there may be people who disagree with this, whereas very relevant was fatigue, mobility, pain, contentment, social and family roles, symptoms as well. So you can see that the point I guess I'm trying to make is that the study of quality of life is very, very complex, and you do need experts in quality of life to help understand this. So this work is in progress, but there are also other ways which I feel are very important to help us understand quality of life, and other than questionnaires, because questionnaires have their limitations. They're a snapshot. It's often difficult to remember, when what you felt like at a certain point. And it can be confusing at times, especially when you may be unwell, etc. So I'd like now to discuss the experience we've had in a study of using wearable technology, which helps to remotely monitor health and quality of life in patients with WM. And I'd like to thank the collaborators at Sanius Health Limited, a UK digital health company, who prepared these slides for the presentation. The idea behind wearable technology is that it can actually measure your various parameters and biological and health-related measures in real time and feed that into an ecosystem which keeps track of what's going on. So what it does is it empowers patients to monitor their health using a wearable technology app, such as a watch, which in fact in our case was a watch, and connected to an app on a smartphone, which then provides real-time tracking of key health data. And this, with time and analysis of large numbers and a buildup of data, helps us to improve our understanding of the condition, and the hope is it will enable more personalized care. So this study has been rolled out actually in a number of hematological disorders within the UK. The first one was actually sickle cell disease, which is a red cell disorder where cells sickle when certain conditions happen. But it's actually been moved on to a number of other conditions, and it's very applicable. It provides real-time tracking of key health data. It improves the understanding of the condition and enables personalized care. And it was developed with patient feedback, and it can help you stay informed. There are many stakeholders who benefit from this, and it can help you actively manage your health as well as keep active. There are activity trackers. I'm sure many of you actually have smartwatches, and there are many on the market. But in a study setting, the idea is to pool data over a period of time so that we can correlate this with treatments that are ongoing, or even people who are on active monitoring, those who've had treatments and no longer on treatment, and so forth. So in this particular study, how does it work? Well, patients with a variety of blood disorders have been approached to consider taking part in the study. And this happens via either their physicians or through patient support groups and various organizations. And following the sharing of information about the study, written and also, well, generally by electronic methods, patients are provided information. They have chance to discuss the details with the team. And if they agree to go on the study, they will then provide written consent to be onboarded. So this all happens remotely. And what they do then is to register interest. They download the app. They then get onboarded via a consenting process. And the wearable device is then sent to the patient's address. And then there is a supported setup to help the person start tracking their health. Then there is ongoing support for continuous assistance, because obviously this is a real-time thing, and any digital application or even piece of technology can sometimes not work so well, and so that is well recognized. And the aim of the support is to help tease out these problems and really make the system work. And then it really provides quality of life tracking. You get data capture continuously. And the idea also, and this gets rolled out depending on the setting and the rules and absolutely the patient's own preference, whether there's an integration with the medical record, because oftentimes medical records are now electronic, and there are ways of the system interacting with the system in an electronic health record at hospitals. So in this particular company's case, and there are many, many companies actually doing this kind of work, it's actually quite a minefield. The feeling is that registry data, which is when you add clinical data to a database in a contemporaneous way, could be greatly enhanced by actually measuring physiological data at the same time and then carrying out correlations. So the idea really is to try and put this data via the wearable tech, via the app, as well as clinical data and quality of life questionnaires, which are also filled out online, because we really want this to be what I call a 4D experience, all the different types of data to be captured and entered into the ecosystem, so that we can then do some really detailed analysis of granular data. It's important to say that the data is held in an entirely secure system and is adherent to all national and international data protection laws. I know this is something that we all worry about, even with Facebook and everything else. You don't know what's going on with our data, but any of these medical digital health projects are bound by law, international law, to adhere to rules about data sharing, anonymization, etc. And I know from my own experience of having the UK registry, the Rory Morrison registry set up, and how that had to be managed in terms of data protection. I know what that involves, and I have seen, this particular application of digital wearable techs, etc. They follow a similar path, which is actually vital. Otherwise, I personally would not be comfortable with this kind of approach. So there is also a WM patient app, which helps you to track your own data in real time and to stay informed with updates. It gives you prompts, like many watches actually, to say, it's time you got up and moved around a bit. And then you can look and see, the various things that come up. So you get, we'll show you in a minute, the sort of things that are tracked. But in essence, you're looking at fatigue, quality of life, sleep, and this integrates into a detailed data set, which is then analyzable. The watch that this company has selected is the Withings watch. Now, there are others, and, I don't know the technicalities why this was selected, other than it has a very long battery life. I know many people have an Apple Watch, and I think they're great actually as well. But in this particular study, the Withings watch was selected. So some people actually have both because they like their Apple Watch. The one of the ideas of this sort of study is that you can have visibility and perhaps more of an informed dialogue with your own clinician by looking up your data. You can look at fatigue, vision changes, night sweats, weight changes. And the idea really is to try and improve outcomes. There's a step which I don't fully understand, but I know it's something that is being integrated into many of these kind of projects, is to use electronic and machine learning methods to try and look for predictors of problems. And this has certainly been tested in the sickle cell setting, where patients with sickle cell disease can develop a crisis. It's being used in diabetic settings where you may get hypos or hyper, levels of sugar. And this is a way of warning you that something may happen. And therefore you can seek help and do something about it. This, for example, could apply to blood pressure measurements. We know that certain medicines, such as ibrutinib, for example, can cause a rising blood pressure over time. So it's a way of picking up things that are changing in the background and being aware and also being more engaged, I guess. There is a system in this particular study where there's encouragement to continue to fill out the outcomes, because the more data that we have within the system, the more analysis is possible. This is a bit like what I've said before, but it gives you an idea of what the app shows, for example, how long you've slept for, the quality, the steps you've done, how the blood pressure has varied, the average heart rate, and other things, which, to be honest, I'm not as equipped to discuss as the tech people themselves. But basically all the data points are stored very carefully within a cloud database, which I'm told is part of Microsoft Azure, which is a tried and tested cloud database system. And it's stored for as long as the patient wishes to remain part of the ecosystem. For those who are on a study, the data is kept for up to 10 years. And that's to do with, certainly in the UK, that's the regulations, and then it's destroyed. So it's an evolving field. It's an evolving science as well. And I probably haven't told it as well as some of the technical people can, but I've wanted to just give you a flavor of the kind of things that we're beginning to see coming out of these studies. The data is processed from the wearable tech, from quality of life questionnaires, which are integrated. Now, I already mentioned that there are a number of questionnaires that don't seem fit for purpose, but part of improving them is to correlate them with physiological parameters to see, what are the missing aspects, what could be improved, etc. And then again, the correlation is with individual medical data in terms of, what treatments you've had, for how long, what side effects happened, how many times you were admitted to hospital, etc. So you can link these ecosystems with, for example, in the UK, with a number of national health service systems, which you can apply for, and this really gives you ways of doing a deep dive into a patient experience of their disease. So just for information, I mean, this particular study has been moving to other countries. So they have got a presence in India. In fact, I think one of the IWMF board members is a young man whose mother has WM in India, and he's helped to try and move it into that part of the world. And it has the capacity to comply with US regulations, etc. So, things are possible, and it's exciting to see that these kind of technologies are beginning to yield results for us as practitioners. So in terms of scientific publications, and this is actually an abstract that we're presenting at ASH this year, which talks about the feasibility of advanced remote health monitoring in WM. In due course, very happy to provide a summary of this for you folks. It's a bit technically presented, but you can see that there are a lot of data points that come out, and the usefulness of this means that we can begin to evolve the direction of travel in terms of treatments, because it talks about people who are on BTK inhibitors as opposed to chemoimmunotherapy. And this is one of the hot topics of WM, how do they fare one against the other? Chemoimmunotherapy is fixed duration, but it's basically DNA damaging treatment. That's traditional ways of treating the disease. The modern therapies, such as BTK inhibitors, BCL2 inhibitors, are oral treatments. It's like a blood pressure tablet. You take it as long as it works in this case. But over time, things change, and it's important to really measure the experience of people having these therapies. In my own clinical experience of looking after patients, we have, I think, over 100 people on BTK inhibitors at our center. Some are in trials, some are not. And they're wonderful, wonderful drugs. But as time goes on, some people do develop side effects and difficulties, which means that we need to reduce the dose or pause it. And I think getting granular data of what happens in between clinic visits is really important and useful. It also helps us as a community to then go back to companies developing drugs, but also organizations like the FDA and the EMA, the European Medical Agency, when trials are being developed, to explain, that this sort of work is being done in parallel with clinical drug development, because that actually gives a lot of weight to arguments about whether certain drugs are better than others. At the moment, there's quite a dearth of this information because we've been relying on rather generic questionnaires, as I mentioned earlier. So that really concludes the bit about the wearable tech. And I thought the last bit of the talk is really about just general themes, which I think are worth mentioning. So in terms of the different domains, physical, it's nice I think it's quite nice to categorize them, because it helps us think through the kind of challenges that are faced, because sometimes it can be a big jumble, both for the patient as well as the doctor when trying to sort out what's happening. But physical wellness has many components, and I get often asked questions about these sort of things. So nutrition, obviously proper nutrition is very important. What does that mean? Well, balanced nutrition, things eating. I mean, we're omnivores, sort of in terms of how we evolved. And of course, some people have different approaches to or preferences in their diet, or indeed intolerances. But it's important to kind of be aware of what you're eating. And if you are not able to eat certain things, then to make sure that perhaps you take some relevant supplements. Think about supplements. It's really important not to have too many of them at too high a dose. There are lots of things promised out there where very high doses of various supplements are recommended. And I always say to patients, it's not a good idea, because there is something called the recommended daily allowance. This is something that is worth adhering to. So having a varied diet helps in supporting your energy levels and nutrition. And there are sometimes variations during the course of treatments that you may be advised by your treating team. Exercise and activity is super important. It helps in innumerable ways, not just strengthening your muscles, keeping you fit, but it improves your mood, your overall health. It just provides you with more capacity to deal with the unexpected. If you become unwell, but you're generally quite fit, then you will tolerate that period of being unwell better. So I cannot emphasize enough the need for regular activity, whichever form it takes. There are many different ways of exercising. It's useful to maybe get some, if you have specific injuries or problems, it's a good idea to maybe get at least a one-off opinion from someone, a physical therapist or a trainer, just to tell you, look, do this or avoid this or whatever. And you can build up over time. Sleep hygiene is actually very important. It's worth getting a good level of sleep, trying to regulate your sleep. As I mentioned before, sleep apnea can be a problem, but it can be fixed. And managing symptoms is also important. WM is a very talented disease. It comes up with all kinds of symptoms that can be quite a nuisance. Neuropathy is one of them, fatigue I mentioned. It's worth talking to your medical team about this, and indeed sometimes one another, because people have experienced things and they can share good practice. In terms of medical input, it's down to if there is something correctable, then this is something that should be corrected, because optimization of, for example, iron balance can really help and can defer the need for specific treatment against WM if it's just a low hemoglobin that's the main problem and not, for example, a very high IgM. Then there's the emotional and mental health side of things. Unsurprisingly, many people, when diagnosed, experience anxiety and depression. There's a lot of concern about what the future holds, grappling with the need for treatment and what may happen. How long will the treatment last? How will I tolerate the treatment? When I stop the treatment, how long will the remission last? It's something that people deal with in different ways. In my experience, people often do have a huge shock at the beginning, and with time, they learn somehow, usually with help of loved ones, to they kind of form a strategy to manage it in some way. But I think if you develop particular anxiety or depression, you should never be ashamed to, or backward about mentioning that, because there are ways of trying to manage them. I think provision of help for these things varies from center to center, country to country, but it's worth seeking this out if you possibly can. There are many strategies for mindfulness and stress management, which I think Anne Grace is much more well placed to describe than I am. But professional support should be sought. I personally do refer people to counselors and psychological therapists if necessary, although sometimes the waiting times are quite long. There are, of course, a number of support groups, and IWMF is an excellent one. WMUK is one in the UK. There are other ones in different countries, WMFC, etc. So please reach out. There is a lot of resource online. It's best to go for ones that are specific to WM, because then you most likely get the appropriate information that you can use. And yeah, building resilience is very important. Finding purpose, staying motivated, trying to, work-life balance. It's sort of work WM balance, isn't it? Or life WM balance. It's very challenging at times. And again, it's worth seeking advice from your healthcare professionals about, can I work? If I'm having treatment, what can I do? What can I not do? Who should I mix with? All of these things are very, very important. I have a patient who recently was diagnosed, and he had a fly fishing trip booked, and he was okay. We were still trying to work out whether he should have treatment or not, but I deemed that he should go ahead. I mean, he should do that because it's good for his mind, it's good for his soul. It's an individualized thing, but I think it's important to try and do things if you can when you're feeling able. But yes, under guidance of the clinical team. Connections with other people. We're very social beings, family, friends. Our relationships with these people is so important. Sometimes it can be tricky because you're trying to navigate the illness yourself, and you're then trying to explain it to others, and that can also be hard. Again, many patient organizations have excellent information that you can share with others to help them understand your condition and what you're going through. So advocacy organizations, really important. Then there's spiritual and existential wellness. We all have our own take on this. I've observed in looking after patients that when people are diagnosed, it can really shape their perspective on their life and their priorities. Some are nearish retirement age and they decide to take early retirement. Others may flex the way they work, but carry on working. It's really very individual. But your clinician should really help you to try and make that happen if you possibly can. At the end of the day, you want to be healthy and a useful member of society, as you've always been. And our job as clinicians is to help with that process, with a disease that lasts as long as WM. There are many ways. Some people do turn to spirituality and meditation practices, etc., which I think are fantastic. I myself think about these things sometimes and would love to take part in these more than I perhaps do. And just looking, keeping things like diaries and gratitude diaries. I myself have tried these, even though I don't have WM, but if there's stressful times, it's good to be aware of what is going well. I think that can be very helpful in the face of challenges. And so, I think in terms of practical aspects, when you're diagnosed, you may well need to adapt and develop a new routine for yourself, depending on where you are in your illness. If you are just diagnosed but physically well, you can probably carry on doing exactly what you normally do. Even if you have disease that is around and may need treatment, an assessment of your immune system, which sort of blood tests and things can give some idea of what your immune system is like. In my experience, in spite of the numbers that you see on the lab screen, it is often what actually happens in person that is what counts. So I sometimes see people who have very low antibody levels, but actually they're fine when I ask them, how are you? Have you had infections? So it's very much a case of how the person is feeling, but also correlating that with the individual's blood. It's good to be in touch with a good care team. Many people look after WM patients, and if you can, it's good to seek out specialist help if you feel you need it. Some clinicians haven't seen much WM, and from our point of view, in the clinical side, we're on a mission to try and spread the word about WM and how it varies from other lymphomas and how it should be treated differently if necessary. And I think just being empowered is really, really important. And the fact that you guys are on this call is a testament to that. I think learning about the condition to the extent that is comfortable for you, because it's a very technical subject, is, I think, really helpful, because then you can talk to others, even healthcare professionals who may know less. And in fact, you can signpost them so that they can understand WM better. And also being aware of, the up and coming trials that are happening, because there's a lot going on in WM, which is really, really positive. We just came out of the international workshop in Prague, and I believe there will be a report of that in the Torch magazine coming out soon. It was wonderful, and it was the most hopeful conference I've ever been to date. And that is testament to the amount of work and collaboration that's going on in the field of WM. And you guys are really very much part of that. We're partners with you. That's the important thing to remember. So really the take-home message I have is that you can live well with WM, and it's gone up. And I think that the digital space is a very exciting one. I would encourage you to think about it. I'm not pushing people into it. I myself am in an exploratory phase. I want to see how it works in a way that's observational. And at the moment, working with the company Sania's Health, I'm finding it very productive, as are many other hematological groups in other disease areas. But there are a lot of other groups out there who are doing a lot of similar work, and it is the future. So I would advise that it's worth having a think about, and just keeping an eye out for what's coming. And I think that's my last slide. So thank you very much for your attention.
Thank you so much, Dr. D'Sa. If you want to stop screen sharing, I have some questions I've been collecting as we've gone along. And folks, you can continue to type your questions into the chat. I know we had a lot of questions about the wearable technology, and can we get involved? Can we still participate? What countries are, is that appropriate for? And, before we answer those questions, Dr. D'Sa, I was wondering, what were the conclusions? If you could just sort of reiterate this, what were the conclusions that you did draw as a result of collecting all of that data, that Waldenstrom's specific data via that wearable tech?
So the conclusions were that there were differences observed by age, sex, and treatment groups. Which I can mention in a bit more detail. I'll find that section. One of the key things was that it was feasible to remotely collect health data using this kind of technology. Now, we've done it, but there are many other groups doing it out there as well. So it's ongoing process. There was a high level of data completeness. In other words, people wore the watch for a long time. They entered the relevant, they filled out questionnaires on their app. The uptake of biological information was sound and analysis was possible. So there was capture of the relevant data was successful in general. So it was a good pilot project for this. Now let me find some other aspects. Here we go, results. So the median age who participated was 67. The 49% were male, 51% were female. Of those who participated, 16% were on BTK inhibitors, 5% on chemotherapy, 3% in a clinical trial, and 7% on other groups of WM treatments, and another 5% on combination treatments. The sort of completion rate of daily patient-reported outcome measures was about 49%, so under half actually were filling out those questionnaires on their phone. But with the wearable information, there was 85% data collected, and it was over about, the snapshot we looked at was over 274 days. There was 68% who had completed sleep data, and 79% who had completed activity data. And there's this quite complicated graph, which is really hard to explain actually, which talked about the breakdown between different correlations of treatments and symptoms and sleep, so it's a multidimensional thing, but it was a very, it's work in progress, but the early signs are that it's a really good, interesting way of going forwards.
Thank you so much for going back to that, Dr. D'Sa. I think, there's a lot of excitement and enthusiasm in this room right now of people who would like to be involved. So where are you with this study? Can folks actually be involved? Is this technology available? Can we get the app, et cetera, et cetera?
So I think the most the best way forward is probably for us to have a conversation with IWMF, because they're a great they oversee a lot of activities. I mean, they're obviously at the forefront of research activities as well. So the technicalities is something we need to work out. It is potentially possible. There's some early work in reaching out to US groups, for example, in sickle cell disease, because that was the index disease for this particular company. And that is actually moved forward in US areas. And what that tells us is that we're developing experience that could be translated across to the WM space as well. So the broad answer is it's doable, but of course we need to go through a number of steps. But for example, it's been launched in India, where the steps are, they have their own set of regulations. So it is possible. And what it needs is a good collaboration and close discussion. But I'm glad the appetite's whetted. I think I personally am really I'm honestly excited by it because the data I saw coming out, and as well, I got a lot of confidence because there are a number of other hematological conditions also being presented at ASH for which there's preliminary data and development of apps. So I think it's doable in WM as well.
Thank you so much. And when I got a little snapshot of the study, of course, my eyes rested for a long time on the sentence, increasing activity levels significantly correlated with decreasing symptom severity and increasing quality of life scores. So I love that you were measuring activity levels, and I love that there's something
Incredibly important.
that we can
Yeah,
do.
in fact, the thing about these methods of recording, it's very detailed, and you get so much information, which is far more than you can ever pick up on an, you can do it on an individual basis, but if we're going to try and make sense of it, then the way to do it is collectively. I can see Bob Perry's raised his hand. I suspect he's been involved actually. So I wonder if he has a comment to make as a user.
Yeah, go for it, Bob.
Yeah, I do. Hello, Shirley. So yeah, the wearable data. It's I just want to explain to people how already I've benefited from it. So I've been wearing my watch now for 10 months, and when I saw my consultant back in April, we were just chatting about how I was, and I showed her my watch and all this kind of stuff. And I was just about to leave the room, and I said, "Oh, by the way, about 3 weeks ago, this watch told me that I'd gone into atrial fibrillation. I didn't know I had. I didn't feel any different or anything like that. But my watch clearly told me when it did my ECG, which it does every day, that particular day I'd gone into atrial fibrillation. And so she straight away said, well, we better check that out. So then I was referred to wear a 24-hour heart monitor. And then when I saw her next time, said, yeah, we had a look at it and you're fine. You're good to go. But it was really important because, when you go and see your consultant and they say, how have you been? You said, yeah, I've been okay. I've been doing this, been doing that, had a chest infection then. But you wouldn't remember that, well, because I didn't know I'd been into atrial fibrillation, I wouldn't have even been able to tell her. But it was important that it's just an example really of how the wearable data moving forward is going to be so important for us as patients. And I even printed out some of my data for her on that thing. So it's I think, and in answer to your question, Shirley, I think I'm right in saying that at the moment it's only in the UK and India, but
Yeah.
I know that it will get to us all eventually for sure. It's such a great tool.
Thanks so much for sharing, Bob. That's so exciting, and I really look forward to seeing how this continues to evolve with the wearable technology and how we as a community can be involved. And it sounds like it's very, very helpful just in terms of getting you engaged and getting you engaged in what is actually going on, awareness of these types of things that measure quality of life, like your sleep patterns, etc. So you can improve them on your own. I had a lot of questions or a lot of statements, Dr. D'Sa, that their doctors are not like you and they don't seem to care about quality of life, or they don't, it's not a whole patient care scenario. How can we get this? How can we change this? I mean, I know that a lot of the Waldenstrom's folks that I see in the community are very good at advocating for themselves. But this is sort of seems like a grassroots movement to bring whole patient care into medical care in general. So I'm curious if your hematologist, is your hematologist somebody who will talk to you about a wellness plan? What do you do if they're not? So I had a couple questions and comments along these lines. I'm just kind of synthesizing them.
No, that's a good question. I mean, I think I get very frustrated when I hear that, first of all, people are not listened to. It happens. I see a lot of people for second opinions and such like. And of course, I think all healthcare systems are under pressure, all doctors are under pressure. I have to say the knowledge level has escalated to such a crazy extent that people need to know so much. And so it's quite hard for medical people to keep up. And WM it's, you know, it's a smaller disease for a doctor in general. And how do they know and keep up with that? And I do think it's grassroots, actually. And that is one of the reasons why I always welcome the opportunity to speak at these kind of events, because whoever I can seed these thoughts into, and even maybe just provide a little bit of encouragement or courage to say, you know, this is possible. I know this can happen. Please let it happen for me. Or if that fails, then there is the second opinion option. Now, I can't speak for the US so much because I don't know the rules, but you should be able to have a second opinion. And in the UK, we encourage that. What we're trying to do is to have a number of centres across the UK so that people don't have to travel so much to get an opinion. But I think we just need to keep pushing, because this kind of medical practice is under threat because there's not enough time and resource, and people are busy. And sometimes there's a short supply maybe of empathy. Because, I mean, there's not a funny story, but I've been reading a lot about AI, and someone did a study of testing human people and AI. And actually, it turned out that the AI responses were more empathic, because the doctors kind of were so tired. They just became less empathic as time went on. So I obviously share the pain that people are experiencing. And when I see people, I just try and make sure that we inform them as much as we can so that they know what to expect. Therefore, not demand, but request, and then try and get what they deserve, really.
Got it. Thank you so much. We had some folks raising their hands, but I did want to also, before we let those folks talk, I wanted to get some of the questions from the chat to you. We had some fatigue-related questions, so I kind of lumped them into a section. So, any suggestions to overcome the need for excessive sleep, like 12 hours a night, and sometimes also an afternoon nap, which rules out, going to dinners and concerts, etc. That was one question. And then another, is it normal to still feel fatigued and need afternoon naps 2 months after 6 BNR treatments? The hemoglobin is normal. How long is this fatigue going to persist following this treatment? So those were a couple of our fatigue questions, if you want to take a stab at those.
Yeah, so I think what I have observed is there's a real range of experience, and that pertains to the fact that there's a range of people in terms of who they are, how they are physically. But I've got a patient whose definition of underperforming was that he had to go from a marathon to a half marathon. He said, "Yeah, I'm fatigued. I'm, not managing my marathons anymore." And others who are less fit and have other medical problems and a lot more to contend with, they may have a whole range of other reasons that are chipping away at their fatigue or their energy levels. So I think it's worth doing a stock take of what you're doing. Maybe start off by keeping like a diary over a couple of weeks of just, mapping out how your day pans out, but also trying to think of confounding factors. So if you have an infection, then you're bound to feel unwell. Sometimes it could be a virus or something that happened a few weeks ago. What I often say to people is that the immune system, it's like one thing, but it's actually a busy, very complicated system that never stops working. So it works day or night. Sometimes it's working against something that we don't even know we have. Sometimes viruses may induce a slight something which doesn't cause a cough or a cold or whatever, but your immune system's busy. Then it's worth trying to correlate whether you may have some kind of infection. So do you have symptoms of an infection? Things like sinusitis are quite common in people with WM. Again, if you do truly have kind of chronic sinus problems, for example, it's worth getting that looked at if possible, because that can deplete your energy over a chronic period of time. There are other factors such as frankly, exercise. Are you doing much? It may seem ironic to do exercise when you're tired, but actually that can turn the tables on tiredness. It doesn't happen immediately, but very small steps of exercise routine in your day helps you to resettle some of these imbalances. I think the other thing is, for example, your relationship with light or darkness, especially in the winter months, it can be a real scourge with you. You don't feel like getting up. I mean, there are ways, there are things you can get like lamps and so on, but it's good to try and get up and get out in daylight if there is any, and try and train your biological clock, your circadian rhythm, to click back into space, into what it should be doing. Now, again, none of these things will happen immediately, and it depends so much on the context of your condition, whether you're on treatment, off treatment. And coming to the other question, when you've had chemotherapy, one has to remember that most chemotherapies like BR or DRC are given over 4 to 6 months. Although they're given as an outpatient, they are turning your system upside down cyclically every month for 6 months. And that gives your system a lot of work to do. You have to, your body goes, oh no, not again, and that's beyond what you may feel in terms of sometimes you get nausea, vomiting, or whatever. It takes time for recovery from chemotherapy. I know it's disappointing, and sometimes people do say months after, I still don't feel good. I still don't feel good. Again, I always do a little check on things like vitamin B12 and vitamin D. And if that's a bit off kilter, then I will replace that. But it can take time. One does have to be patient. If what I would put in there, and again, these are my thought process in clinic, if you're particularly feeling certain symptoms like, say, breathless or something like that, then it's worth just bearing in mind other things can happen to people, even if they have WM. So, it's worth making sure other aspects of your health are good, like blood pressure, heart, breathing, and sometimes if someone is overly fatigued or really dragging themselves around or getting short of breath, then I will perhaps do an echocardiogram it's a non-invasive way of seeing that side of you is fine. And sometimes, yes, that may lead to a further referral, but, better safe than sorry is my motto. So I think be patient. You are patients, but you have to be patients, I'm afraid, when it comes to chemotherapy recovery.
Thank you, Dr. D'Sa. Hang in there, those of you with your hands raised. I do want to have you give you the ability to ask your questions directly. We are still recording. I have a couple really more specific questions from folks, and this is sort of a mini case study for you. I have received an email from Peter Lunnan, and he is located in Buckinghamshire in England. He was diagnosed in 2013 and received 6 rounds of RCP and responded well. In 2020, 2021, his paraprotein level had increased again, and he had another 4 rounds of RCP. For those of you who don't know, that's rituximab, cyclophosphamide, I think that's how you pronounce it, and prednisone. Earlier this year in February, his paraprotein had gone up and he started zanubrutinib 80 milligrams twice a day, a lower dose due to interaction with other medication. His paraprotein has come down to 4, but he's continually exhausted and fatigued and have painful limbs, especially arms. It is completely affecting my quality of life, and I'm really struggling on a daily basis. Could this be a side effect of the zanubrutinib, or is it still related to WM symptoms?
Yeah, it's a bit tricky to answer without knowing some of the data, because it depends on the trend in the IgM as well as the hemoglobin, for example. As you mentioned, it's a lower than normal dose. In my experience, zanubrutinib itself doesn't induce fatigue unless it causes a side effect such as a cardiac arrhythmia. And if you happen to develop an arrhythmia like AF or something like that, you may quite often people are aware because they feel palpitations, but if not, then that is an area that one should just be aware of. Is there any sort of problem there? Other than that, I've forgotten exactly the timescales, but it's not a side effect of Xanu per se. I can see the paraprotein is now 4 grams per liter. What I would say about BTK inhibitors is that they're quite slow to clear the bone marrow. And when your bone marrow is busy with lymphoma, even if it's low grade, it's still giving your system extra metabolic activity on a chronic basis. And finally, it's worth knowing that there are some people have a rather extra inflammatory version of WM. So I sometimes get a CRP and an ESR measured. And if there is, particularly if there are aches and pains, etc., I do a sort of inflammatory check in case there is another aspect to their WM. There's a very rare condition called Schnitzler syndrome, which is indeed rare, but it's important to pick it up if it's there. I'm not saying this gentleman in Buckinghamshire has that, but I'm just saying, just food for thought. If someone turns out to have very chronically raised inflammatory parameters, there is a treatment for Schnitzler syndrome. It's a sort of a cytokine blocker. So I do seek it out when people have extreme symptoms of either fatigue or aches and pains is a very common one, or fevers, or it doesn't quite sit well with WM on its own, as it were. So just to mention that there is something there that is very rare, but if it's picked up, it can be treated very effectively. In addition, I mean, it doesn't always respond to the Xanus and the chemotherapies of this world.
Gotcha. I have one more specific question from Francine. She writes, in terms of quality of life, post-DRC treatment, how long can it take for someone diagnosed with axonal sensorimotor polyneuropathy for about 2 years to start feeling improvements in the neuropathy condition? And then we're going into a topic that is, something you do many webinars on, neuropathic pain. So that's one specific question from Francine. How long can it take for this to start feeling better? And then additionally, in that category, I have many folks asking, what are your recommendations for addressing neuropathic pain without medication? So those are just 2 questions we would have. If we have time for them, how are we on your time, Dr. D'Sa? Are we okay?
I'm okay. Thank you. Yeah. So yeah, it's a big topic of its own, to be honest. And again, the devil is in the detail. So it depends on the cause of the neuropathy and the features of the neuropathy, because one of the most commonly studied one, anti-MAG neuropathy, it's not something that causes very prominent pain, although it can cause tingling and other sort of abnormal sensations, for example. So it's a really hard one to answer in a generalized way. If we assume, in this case, that the neuropathy is related to the WM and the DRC was given to try and get that under control, it depends a little bit on the nature of the nerve damage, what is most prominent. If it is a damage to the wiring of the nerve, then that can sometimes, there can be a limit in the rate of recovery and the degree of recovery. If there is a super added what's called small fiber element, which are the little fibers of nerve fibers in the skin area, particularly marked in, where we need them, then that tends to respond poorly to treatment, I have to be honest. And then you are needing to have things that modulate the neurological system to sort of calm it down so that you get less of the sort of jangling signals. And there's a range of things that can be used for neuropathic pain and discomfort. So yeah, it's really hard to generalize on a question like that, to be honest. I mean, yeah. So it may be worth looking at some of the other webinars and things, because I try and touch on some of these topics in those.
Yeah, well, let's come back to that one because I think there's a lot to explore there, and we'll do that some other time. But I do have two folks here who have their hands raised. Molly, thank you so much for your patience. I will give it over to you to ask your question directly if you want to come off mute.
Hi, can you hear me? Yeah.
I can.
Okay. So yeah, hi. Actually, I had just a comment for the rest of the attendees when you mentioned about second opinion, and someone in the chat had asked about in the US. So I live half time in Sussex and half time in LA, and I'm American. So my insurance is only there. And my oncologist who diagnosed me in July in Los Angeles, he was very happy to write the referral for me to go for a second opinion at Dana-Farber. And in fact, Dr. Castillo at Dana-Farber works with other patients that my doctor in LA has. And before I went off to Boston, the doctor in LA said that he will assist, and then Dana-Farber will lead my case. But when he had originally diagnosed me, he said he had 20 patients with WM, but hundreds with other lymphomas, so that it would be absolutely within the realm of having a second opinion. So I want to just let people know how easy it is to happen. And I'm on Medicare. So with Medicare, it works anywhere in the US for that. So just to let people know, your doctor will be very happy that you're asking a second opinion if they're not a specialist. Because I know some people in the support group on Facebook have been sometimes concerned, will that set my doctor against me? No.
It's useful.
Thank you so much for sharing that. And I do have, actually, Joy came back. So Joy, would you like to ask your question? Because I know you have to leave soon.
Yeah, sorry. Apologies. Thank you. I thought I'd have to go. Thank you very much for a great session. I was just going to comment on where we were talking about some people. I'm very lucky. I have an excellent consultant, but some people do have trouble with their hematologists not taking WM seriously. I do have a watch, and I just want to echo what Bob said about being able to talk to your consultant about your symptoms and just about the disease. I think one of our problems is that a lot of people think that our symptoms are just getting old, and we are older people, and we just have to acknowledge that. And I think the more information we can have about ourselves, and I absolutely agree, have a diary, take notes of what's happened, and see how things change, so that you can talk properly. The more we're informed, the more we can have sensible consultations with our clinical staff, the better we're going to be treated. And I would just really encourage people to do that.
Agreed.
Wonderful. Thank you for sharing, Joy. So we still are recording. If you would like to, if you're comfortable being on camera and you have a question, you can raise your hand. I see that Craig and Sandy have their hands in the air. So Craig, if you're comfortable with being on camera, go ahead and unmute and ask your question of Dr. D'Sa.
All right. Thank you very much. I also echo my appreciation. It's been a wonderful presentation. Just curious as to how common and also how impactful it is to have multiple lymphoma diagnoses simultaneously. Excuse me. I've been diagnosed with both follicular lymphoma and WM. And what's your experience with that, Doc?
So yeah, we have a few patients who have dual diagnoses of lymphoma. Not so much follicular, actually, but we've got some who have CLL, chronic lymphocytic leukemia, and WM. There is also an overlap between marginal zone and WM. So we have had to bear that in mind when considering which lymphoma is misbehaving, because the treatments are similar but different. So I think our approach to someone who has dual histology lymphoma is to try and work out from the staging, from the bone marrow, the scanning, and if necessary, lymph node biopsies or whatever, to try and determine which entity is more dominant in terms of symptoms, if indeed perhaps both of them are quite quiet and neither needs treatment. But if one is being more active, then it's important to try and understand which it is, because the treatments for follicular lymphoma are a little bit different to the treatments for WM. There are many shared treatments, but for example, BTK inhibitors are a WM treatment. And so if it is the WM that's the main problem, it's worth being aware and targeting that appropriately. So yeah, it depends exactly on the balance. And sometimes we've monitored both over a long period of time and then decided, disease X or Y is the predominant one, and therefore we will go down that path. But of course, keeping an eye on the other. And you find actually that many treatments will actually treat the other one as a side effect, which is not a bad thing. I don't know if you've got a story that tells us which one is worse, or
it started with the symptoms from the follicular in terms of small tumors and creating some pain, but through the process and all the different scans, they came up with the WM, which had, as you have mentioned in the beginning, it had been around apparently for a long time developing, and
Yeah.
I have over 80% bone marrow infiltration with that. So they are doing a BR approach for the first 6 months.
Thanks for your question, Craig, and hang in there. It sounds like you're going through a lot. We'll be thinking of you and appreciate you being in our community today. I have time for one more question on the recording, and then we will turn off the recording. And if there's maybe one or two more questions, we'll do it from there. So Sandy, you had your hand up.
Okay. I was wondering, I've had WM for a long time, since 2007. I've done different treatments. I'm on a clinical study now. And I wanted to know how other health challenges affect your WM. Like this summer, I had a fall where I broke 2 limbs. I broke my patella and I broke my wrist. And it's affected me as far as doing physical things and, getting over this. I don't know how people who work with people with WM deal with other challenges the person has, because we're all getting older now. I started out when I was 60 and now I'm 77. So I just wanted to see what you had to say about that.
Yeah, that's a long time. And sorry to hear about your falls. My approach would be, first of all, to understand why the fall happened. Because again, if there's a medical reason, then that needs to be addressed. So on the other hand, if it was more of a mechanical fall or just a trip or something, then that sometimes happens. I think we do ask the question, for example, if someone has a fall and has fractures, we do ask whether WM could be instrumental in the fracture. It's not commonly known to cause bone damage. There's a condition called multiple myeloma, which is famous for causing bone damage. In fact, most people with multiple myeloma have fractures and lesions in their bones. But some people with WM can develop bone infiltration, and that can cause certainly bone pain. I have also witnessed in some patients that they can get generalized thinning of the bones. Again, this is not widely reported. And in someone who's postmenopausal, for example, there may just be benign, natural reasons for bone thinning. But one of the things we would do is to try and explore whether the WM could have been instrumental in the fracture, look at bone health, possibly do a DEXA scan, make sure vitamin D and things are intact. And if there's any hint that the WM could be instrumental, we would interrogate that in more detail with appropriate imaging. Sometimes WM can become a little more aggressive, and sometimes a PET scan can help as opposed to a sort of normal, as in inverted commas, CT, or an MRI scan can sometimes be of help. But you're right. I mean, it's more common for things to happen as we get older. So it's really the summary, I guess, is look in detail at why the fall happened. Was there any WM related damage to the bone underlying it, what we call a pathological fracture, although that's quite unusual? Look at bone health in general, and try and optimize recovery and rehabilitation as much as possible. But obviously continue to keep an eye on the WM to make sure it's treated when necessary. Hope that helps.
Thank you.
All right. Thank you so much, Dr. D'Sa, for your time. I'm going to close up our webinar with a little bit more information. We'll turn off the recording and be able to spend a little more time together. Whether or not Dr. D'Sa has time to stay is up to her, because she's on a family trip right now. So if you loved learning from Dr. D'Sa today, please let us know on our follow-up poll, which we'll be sending out along with the recording of this session. So you can go back, and there's a lot of information that was presented today. You'll be able to go back to that recording. And if you're interested in improving your quality of life with our IWMF wellness classes, you can go to the IWMF website in the Patients and Caregivers drop-down menu to learn more and to join a class. I'll also pop that resource into the video description on the YouTube site. You can also reach out to me directly at anngrace@iwmf.com to find out which offerings might work best for you. And so I would say, Sandy, with what you have going on, a chair yoga class might be more appropriate than some of the more, cardio flow type classes.
Yeah, I've done some. So I've done some of your classes, so I think they're excellent, and I appreciate you doing that.
Wonderful, and we're so glad to have you. Our next wellness webinar, Dr. D'Sa, you're invited to this. It's December 19th, and we're going to be doing a holiday self-care webinar with a massage therapist who's also a Waldenstrom's caregiver. She's going to share some simple practices like acupressure that can help us become more present and reset the nervous system during this busy time of the year. That's on December 19th. So thank you all so much for being here today. Thank you for your great questions. If I didn't get to your question, stick around or email me, and we'll continue to look for just wonderful work coming from Dr. D'Sa. Thank you so much, Dr. D'Sa.
My great pleasure. Thank you. I do have to head off, but it's been a pleasure to see and talk to you guys. I wish you all well. I wish you, as you say, happy holidays, and look forward to seeing you soon. Take care all. Thank you.